Okay, I'll start letting everyone in. Let me remove the waiting room. Hi, everyone. Thank you so much for joining us today. We'll get started in just a moment. All right, I know people will be trickling in, but we'll go ahead and get started. So, hello and welcome, everyone. Thank you so much for joining us today for eating disorders in South Asian communities. We're really grateful you're here for this important and thoughtful conversation. Today's session is led by Runjhun Pandit, founder of Wellbeing Den. She will guide us through how eating disorders can present in South Asian communities, the cultural and family contexts that shape these experiences, and pathways towards compassionate, culturally responsive care. Before we begin, I'd like to just say a quick note that today's session will be recorded and will be posted on our YouTube and social media channels. Also, if you have any questions throughout the session, please feel free to drop them in the chat box and we'll have time for a brief Q&A at the end. We can go to the next slide, please. Thank you. So I'll start by doing a quick introduction about myself. My name is Nisha Uddin, founder and CEO of South Asian Care. We're really happy to be hosting today's webinar. Some of you may have joined our previous events or visited our website, but our mission is to advance health equity and improve access to culturally compassionate care for South Asian communities. So we have a number of areas that we focus on, including our provider directory, our resource hub, and community events such as this one. So we're always really happy to collaborate with different types of people and topics. And today we're pleased and delighted to partner with Runjhun for this awesome session. So without further ado, I'd love to go into a quick introduction for her. Thank you. So, Runjhun Pandit is a licensed mental health therapist practicing in Washington, Delaware, and California, and the founder of the Wellbeing Den. Her clinical work focuses on the assessment and treatment of eating disorders and perinatal and postpartum mental health concerns, with additional specialization in supporting tech professionals and individuals navigating major life transitions. Runjhun practices from a trauma-informed, culturally responsive framework, attending to the intersections of identity, family systems, performance-driven environments, and mental health. Through Wellbeing Den, Runjhun provides evidence-informed care to clients addressing challenges related to food and body image, pregnancy and postpartum adjustment, career-related stress, and identity shifts across the lifespan. So we're really pleased to have you today, Runjhun. Thank you so much for talking on this very, very important topic. And I know I also just want to say another quick note. I know this can be a heavy topic for many, so if anyone ever needs a moment or breakthrough out, please feel free to take it. And take it as you need. So without further ado, I'll pass it over to you to get us started. Thank you.
Thank you so much. And thank you everyone for being here. I'm super excited about this. So today what we are going to start with more is understanding like how they present differently in South Asian communities, recognizing the cultural, familial, and the migration related risk factors that sustain the disordered eating patterns. Learn more about like how to apply assessments in a more culturally responsive ways, and hopefully leaving with more like practical and culturally effective treatment adaptations. This is all something that I use a lot in my own work. So this is heavily informed from like obviously what we see from research perspective, which we all know is limited, and at the same time what I have used with my clients across these years. So let's start by like widening the lens. When most people think about eating disorders, they picture one very specific image, usually thin, white, teenage, and a female. But eating disorders don't have to be one face. They don't have to be one body type. They don't also have to be one culture. And you will be surprised that even when you actually type eating disorder on Google and click on images, you will see white individuals. And that's how it's stereotyped in our life as well. So even as clinicians, many of us were, I think, even when within the textbook mind frame, like trained to picture it for a thin white teenage girl. And that stereotype does a measurable harm. It has contributed to underdiagnosis in communities of color, including South Asians. And eating disorders are not rare in our communities, they are often misinterpreted or ignored. So, eating disorders are a serious mental health condition that involve disturbances in eating behaviors, body image, and one's relationship with food. But underneath that, there are often about coping mechanism, control, emotional regulation, identity, and belonging. So there are, if you include these patterns of restrictive eating, there are a lot of food rules. There's a lot of fear of intense weight gain, chronic dieting, or feeling out of control, and feeling out of control in general, not just in terms of food, but in their lives as well. So importantly, you cannot diagnose an eating disorder by just like looking at someone's body. So, what are they actually doing? So, clinically, eating disorder fall into categories like anorexia, bulimia, RFID, that is avoidant restrictive eating disorder, and binge eating. But outside of these diagnostic labels, what we are really talking about is distress. What we are talking about is food becoming moralized, that is good or bad, body size becoming tied to worth, and shame attached to hunger, and eating becoming emotionally loaded. So, when we look at the data, disorders are far more common than most people think. In the United States, nearly 1 in 10 individuals will be experiencing an eating disorder in their lifetime, and that includes anorexia, bulimia, binge eating disorder, and RFID. Binge eating disorder is actually the most common and it affects people across all body sizes. And eating disorders have one of the highest mortality rates of any psychiatric illness due to both medical complications and suicide. But here's what's critical: they affect all genders, race, age, and socioeconomic groups. But diagnostic rates don't always reflect the prevalence. So, communities of color, including South Asians, are often underdiagnosed and not under affected. So, when we talk about epidemiology, we're not just talking about numbers, we're talking about who gets seen, who gets missed, and who gets access to care. You'd be surprised. So when I was looking through this, I was actually looking at like, I'm sure there are much more research available. I'm sure like there is a lot more available in this field about South Asians or people of color. And I was surprised to see that the most recent one was a systemic analysis of the prevalence of ED across South Asians done between the years 1990 to 2021. And it was surprising to see that it was more about recognizing that the age standardized prevalence rates of EDs increased significantly from 1990 to 2021, with binge eating peaking in the group of 20 to 24 and anorexia peaking in the group of 15 to 19. Obviously, females exhibited highest rates of increase, while notable rises were also observed in males. And I say it obviously because, as we all know, it is so stereotyped in our brain that females were taken part of, and this is a limitation that they have also mentioned, that there were more females who came forward and were willing to be part of these group studies. So what happens is we want to talk about like what is it that we missed and why are eating disorders missed in South Asians? Because one of the thing is the white illness assumption. Historically, eating disorders have been portrayed as illnesses affecting thin, affluent white teenage girls. And that stereotype shapes by media representation, clinical training, screening bias, and even self recognition. So, when a South Asian adolescent or an adult struggles with restriction, binging, purging, it often doesn't match the mental image that providers expect. And as a result, providers may screen less, and families may not consider it, and individuals may not identify their own symptoms as an eating disorder. Another part is family concealment. Collectivist family systems prioritize harmony and reputation. Mental health struggles can feel like a private family matter, a threat to marriage prospects, a reflection on parenting. So, behaviors may be minimized, hidden, or reframed as just picky eating, just stress, they are very disciplined, and secrecy delays those interventions. There is also systemic weight bias. So, if a South Asian patient lives in a larger body, disordered eating behaviors may be praised as, oh, good, you're losing weight, good job. Keep cutting those carbs. Conversely, if someone is underweight, providers may assume that there is no problem at all. But eating disorders occur across weight categories. And when weight is the primary diagnostic lens, many cases go undetected. Hence, eating disorders are missed not because South Asians are not affected by it, but because they are misread. And so, if we only rely on stereotypes, we will overlook the suffering. So, culturally competent care requires asking different questions, listening beyond the surface, and recognizing that eating disorders do not only look one way, they adapt to context. One of the main things that we have noticed, and I have also noticed when I'm working with clients, is there is somatic language in eating disorder presentation across South Asians. So, in many cultures, psychological distress is expressed somatically. We all know this is because when we express any physical discomfort, it does not have a stigma attached to it. People highlight it, and parents or families will go and run to make sure that that is taken care of. Versus mental health concerns do have a lot of stigma. So instead of saying, like, I'm afraid of gaining weight, someone might report, I have so much stomach ache. Oh, I'm so bloated all the time. I feel tired. There are digestive issues. There's a lot of appetite due to stress. And these symptoms are real, but the underlying driver may be anxiety, shame, or even body dissatisfaction. So, if we only treat the gastrointestinal complaints, we miss the eating disorder entirely. So, when we are assessing restrictive eatings, we have to widen the lens because restriction does not always present as I'm afraid of gaining weight. It can be framed as discipline. Restriction as discipline is often praised in many households. Self control is moral, appetite control is strength, and thinness can be associated with willpower. And hence, the restrictive eating gets reinforced and not questioned. An individual skipping meals might be described as, look, they are so focused. A teen cutting cards might be praised for being health conscious. The behavior blends into the cultural values around self discipline. Another aspect is also if they're preparing for a wedding, there is also this sanctioned period of dieting before major life events and especially weddings because they have this concept of I want to get into shape before I get married, and I want to slim down, and I want my photos to myself to look very slim in those photos, looking your best for the family. In these contexts, extreme restrictions could be normalized and even encouraged. So, what might clinically resemble anorexic behaviors can be reframed socially as preparation, beauty optimization, or family pride. There is also a lot of health masking that comes into place. Making sure clean eating, avoiding sugar, making sure they're taking care of their cholesterol levels. So restriction may also hide behind these medicalized language. I'm cutting rice for cholesterol. I'm avoiding oil for health. I'm just eating clean. While genuine health conditions absolutely exist, rigid elimination, moralization of food, or significant calorie restriction can be marked as cardiometabolic responsibility. And this is particularly salient in South Asian communities, where rates of diabetes and heart diseases are elevated, making health based restrictions socially reinforced. Then comes religious fasting. As we know, right now there is Ramadan that's going on, and religious fasting adds another important layer to this. So, practices such as Navratri, that Hindus celebrate, Prayushan, that Jainism follows, or Ramadan, that is followed by Islam, they're spiritually meaningful and community centered rituals. So, fasting in itself is not pathology. The clinical question becomes, is the individual able to resume flexible eating afterwards, or does the fasting period intensify the pre existing restriction, guilt, and rigidity? For some, religious fasting is devotional. For others, it can become a culturally protected container for disordered eating. Is this behavior flexible or rigid? Is it spiritually meaningful or fear driven? Or does it enhance their life or shrink it? Because in collectivist and religious context, restriction is not always labeled as illness. It is important for us to ask these questions. But culturally informed care requires us to look beneath all of these labels. It is to really listen to the story of what they are saying and what they are explaining as they are in the room with us. Another aspect is migration related food changes. Migration does not just change geography, it changes the food availability, food meaning, social eating structure, body comparison standards, the control dynamics, family power hierarchies. And for many South Asians, food is identity, and migration destabilizes that identity. There is a loss of familiar food environment. So after migration, traditional ingredients may be harder to access or may not taste the same. Time scarcity increases reliance on processed foods. Nuclear family replaces extended family meal structure. There is also a psychological impact because there is food insecurity anxiety, even if they are financially stable, because they might be situated in areas where there might not be a lot of South Asian stores. So they have limited understanding of what they could eat and whether or not they would find the kind of food that they like. There's a loss of sensory familiarity, which causes a lot of distress. Like the food might not taste and feel and smell and look the same. The nostalgic eating or rigid preservation of home food. There is an increased reliance on food as cultural anchor to ensure that they don't feel lost. And eating disorder risk leads to a heightened control behavior around authenticity. So they would focus more on, no, I have to make it in a certain way. I have to ensure I eat only home cooked food. I have to make sure that I get these ingredients have to look like this. Only these things can go in this vegetable or the recipe that I'm making. Restrictions of non-home foods also arise, and that also triggers ARFID behaviors. That is, avoidant and restrictive food intake around textures, around smells, around the way it looks. So more sensory sort of behaviors. Binge eating is also tied into scarcity mentality, like what we all have heard growing up, or most of us have heard, is we don't waste food. Then acculturation and Western food conflict also happens, which causes this sense of identity destabilization. Like, for example, at home, there is rice, there is roti, there is dal, there are curries. In communal eating, but outside, there is a lot of calorie counting culture. There are protein shakes, there is clean eating, there is fast food. And we recognize that there is a lot of fast food normalization, which causes a lot of tension across clients as well. I've had clients report feeling embarrassed bringing traditional food to school. Often, this is often when I used to work with adolescents. They would say, like, I don't want to take the tiffin that my mom or my dad sort of packs for me. They've had experiences of being teased for smell or appearance of their food. Oftentimes, when they would like cook or their families would cook curries in the house, there would be a smell that would stick onto their food, that on their body, on their probably outfit, and that would also be teased by their peers, comparing their meals to their peers. And this creates the shame around cultural food. There's a desire to eat more white. There's an internalized belief that Western food is superior or healthier. And what happens is the restriction of traditional foods, like especially carbs, increases. There is an orthorexic adoption of Western wellness culture. And then disordered gym culture also comes in, specifically in boys. That I have to look a certain way. I need to have a muscle mass. I need to have more proteins. I need to make sure I am always lean and looking like my Western counterparts. Then there comes a scarcity mindset. Many first generation immigrants experience economic instability, political unrest, rationing, and financial sacrifice for children. The message that they get is food should never be wasted. Finish everything on your plate. I have heard it a million times. We didn't have this growing up. And what happens? What does the clinical outcome come? Is children may lose hunger cues and hunger awareness because of the finish your meal sort of club and finish your plate. We lose the sort of hunger cueness is, I guess, like I'm full today and I don't want to eat, and feeling the guilt when they don't eat what is cooked at home, developing binge eating linked to guilt or shame cycles, or even use of restriction to reclaim autonomy. There is shift in body ideals as well post migration. So in some South Asian regions, slightly fuller bodies historically associated with prosperity are very well celebrated. In Western contexts, thinness is equal to discipline and success. So, migration exposes families to BMI discourse, diabetes stigma narratives, media driven thin ideal. And what happens is parents who once praised fullness now police the carbohydrates. They enforce dieting for health. They comment on children's weight earlier than before. And this hybridization of ideals increases confusion and anxiety. And post migration, some families increase religious fasting to preserve the culture, emphasize dietary rules more rigidly. And clinically, it is important for us in all of this to assess, is fasting grounded? Is this reinforcing restriction? Is migration a part where they start feeling like, oh, I have started questioning where I am coming from? Because it can intensify not only religious rigidity, which may lead to more complicated eating disorder patterns. Another thing that I go more into when I'm working with clients is food as an identity. Food, when food becomes a cultural survival process. Because for many families, especially the first generation immigrants, cooking traditional food is not just about taste, it's about preserving heritage. It becomes a proof that culture has survived migration. This means food carries those emotional weights, it's a memory, it's a sacrifice, it's survival. And when we understand this, we see why conflicts around food could actually escalate so quickly. It's not just about rice or roti, it's about identity continuity. Another aspect is about family and collectivism. In many households, identity is not purely individual. The self is relational. You are someone's daughter, son, cousin, sister. That means the body is not always seen as purely personal. It can be experienced as a reflection of the entire family. Food is equal to love and respect. Food is rarely just food. It is hospitality, it is sacrifice, it is respect, and it is love. So when an elder serves you food, it's not only a meal, it's care. So if a child or an adolescent is refusing, restricts food, diets, or avoids certain dishes, it may be interpreted not as distress, but as rejection. And rejection of effort, rejection of culture, and rejection of love. So comments are normalized, right? Like comments in terms of your body size or how you have gained weight, a certain color, who will marry you if dot dot dot. Don't eat too much, don't eat less, this is too much, this is too less. And these are often framed out of concern or guidance and not criticism. But we all know, once there is a repeated surveillance, it can internalize that sort of shame. When appearance is regularly evaluated in communal settings, weddings, festivals, family gatherings, the body becomes more of like a public property. The body is looked as, if I am being a certain way, if I am looking a um, certain size, what will people think about my own family? What would that look like in terms of my marriage prospects? What does that look like in terms of my social standing, my perceived discipline? even parenting success. So the stakes really feel high. And this can create pressure, especially among girls, to manage the body not just for themselves, but for their family. Coming back to the clean plate club, that narrative that there is an expectation, that underlying expectation when a plate of food is kept in front of a South Asian is, I have to finish this. I'm not sure if I even have the space to finish it, but I know I have to finish it. So, for many immigrant families, food scarcity and migration could really shape how they take care of wasting food or feeling morally wrong. So, children are taught finish everything, don't waste food, and be grateful. And while the intention is gratitude, it can override the internal hunger and fullness. And this disconnection from these cues contribute to either restriction patterns or overeating patterns as well. Another, as we are talking about marriage, in many cultures, it is we know that body is not treated from a private as a private property, but as more of a social asset. So weight is explicitly tied to marriage prospects. The comments like just lose a little before proposals start coming are normalized and framed as love or preparation. So thinness becomes a code for discipline, and this creates a chronic hyper awareness. So many clients tell me that they felt like watched long before they felt autonomous. There's a lot of cousin comparisons as well. Like, oh, you look at that cousin, they have slimmed down before their wedding. Oh, they rarely ate anything. Oh, this color looks better on them because it helps with their body color in general. This is set and sort of like an expectation that transformation is required for social legitimacy. And what makes us uniquely challenging is that the pressure is rarely framed as cruelty. It's care, it's a reputation, it's for your future security. So they internalize it, they feel obligated to sit with it. So in treatment, we have to name this dynamic very explicitly. Otherwise, we miss one of the most powerful maintaining factors. And due to these we I need to fit in these close mentality around marriage, it could trigger if someone is has relapsed because of like these marital propositions. It is the focus has to be less on incorporating what others are thinking and more or around incorporating personal choices, focus on their own physical appearance, focusing on what are their triggers and helping them to be aware about their own body. Because marriage pressure can function as a culturally sanctioned eating disorder trigger. Another thing which is more focused around the first generation and second generation situation around food is that when we are talking about migration, we have to realize that for a first generation, the factors that could cause an eating disorder or feeling like they don't have control over their food could be there is a loss of status, there is chronic stress, there is need for comfort and control, and food becomes the only way to actually sort of feel that they are in control and they feel good about it. So there is a downward career mobility oftentimes. There is social isolation when they move away from their hometowns or their home countries. There is language barriers, there's financial stress, there's loss of extended family. And so food becomes the only thing that they can control in all of these domains. And this may manifest as restriction during high stress, emotional eating after long work days, eating at night, rigid health rules, and binge and restrict cycles. For many first generation, weight gain may symbolize as Americanization. So thinness may represent discipline, fitness may represent success or status, and some internalize Western thin ideals later in life, particularly after they are exposed to work environments, media comparison, healthcare messaging, social media. And this late internalization could trigger an adult onset of body dissatisfaction as well. They may frame symptoms as, again, digestive issues or stress, avoid labeling behaviors as mental health concerns, They may minimize binging as at least I am eating. And shame is often intensified as community reputation concern, fear of being unstable, and lack of culturally competent providers. So many first generation immigrants carry um, this fear of like instability, economic hardships, the scarcity, and some of them could have these newer behaviors after migration, which could be overfeeding their children, hoarding food, which might make them feel safe. Overeating could make them feel as grounding. And for others, restricting feels like a strength and survival discipline. Parents may push food as they care and comment on weight as protection. They would encourage restraint to maintain a reputation. So it's important to understand that as these parents are also sort of working with their second generation kids, the focus is more coming into the idea of they have a higher internalization of Western thin ideal, so that increases the risk of eating disorders. There is also a bicultural stress that we notice often, is that they have a fear of like not just gaining weight, but fear of like understanding the concept of like constant code switching and the fatigue that comes with it, the feeling of too Western at home and too ethnic outside. Then they also have to manage the family honor and reputation. They're also navigating this collectivistic expectations with individualistic environments. And research suggests that bicultural stress actually predicts a lot of binge eating episodes. There is a lot of emotional eating. There is loss of control eating. And there is secret behavioral eating. Because food is more of like comfort. It is rebellion. It is control. It is a private coping strategy. And also, it helps in sort of bridging the acculturation gap. So, when a second generation youth acculturates faster than parents, an acculturation gap is formed. And this gap predicts the increased secrecy around food, high emotional dysregulation. There is a higher shame around body changes, especially during puberty. And then there's an increased compensatory behaviors like restriction, binging, purging cycles. And what happens is when we are talking and we are working with a mix of first gen and second gen family members, it is important to understand and name in the session both these factors that are contributing in their own way and how that is leading to an increase in eating disorder behaviors. So when we talk about, because I work with pregnancy and postpartum, I wanted to also bring this into highlight that how oftentimes individuals feel when you go into history taking, they would say, "Oh, we were doing really well. I never had an eating disorder. I never had issues around my food, and then I became pregnant." And that sort of like made me question, like, what is happening here? Why are they now being so scared about their body or how they look, how the bump looks? And so pregnant body is discussed very openly. The bump size becomes a topic of analysis. Comments like you're too small, is the baby growing, you're getting very big, be careful, are very normalized. Eating becomes moralized. So women are encouraged to and feel also pressured to eat calorie dense strength giving food like ghee based sweets, milk, saffron mixtures, and laddus. And refusing can be interpreted as weakness. At the same time, the Western medical system emphasizes weight monitoring, gestational diabetes prevention. So now these women are caught between two set of rules, right? Eating more culturally or eating less medically. After delivery, the postpartum confinement period can also focus more on healing foods and rest. But here's the tension. Once that window passes, there is a rapid weight loss is often praised. So women may hear, "You still pregnant? Oh, so and so lost her weight in like just 3 months after delivery. Make sure you slim down before that next event." So this also creates a binge and restrict pattern. And overeating during confinement leads to guilt, and that leads to rapid dieting, which could be more form of like a restriction. So for clients with, now think of it as if they had a prior eating disorder condition, right? They are at the high risk windows for relapse post pregnancy. But because the body autonomy shifts, the comments increase, and there's a surveillance that just intensifies. So clinically, what we need to ask is, how do we feel about the comments you're receiving? Do you feel pressure to eat more than your body wants? Are you restricting now because you felt forced to eat earlier? And how has your relationship with your body changed since delivery? Because pregnancy is not protective against eating disorders. In culturally heavy environments, it can heighten vulnerability and it can make the person feel bad about their own self. Now that we have seen like areas of what we need to focus on as we are working with South Asian populations, I want to just briefly highlight the assessments that are usually done. One is called SCOFF, which is a rapid screening tool for possible eating disorders, and it is used more in general settings. So it's a quick 5 minute, five question yes and no. So it is just like a basic level to understand. The second one that we use is eating disorder examination questionnaire. It is self-report version of eating disorder, and it's commonly used in clinical and research settings. The main focus is to use as a wider tool around, is there an eating disorder? Does the person feel like there is an eating disorder, and how does that sit with them? And then the eating disorder eating attitude test is more about specifically emphasizing on, these factors of dieting, bulimia and food preoccupation, oral control, emphasis on dieting and weight fear, and may miss atypical or culturally marked restriction. So less sensitive for binge eating disorder as compared to EDEQ, but it may in general not have a complete understanding of when someone comes in more with a somatic experience rather than typical DSM diagnostics. So what does a typical like eating disorder screening look like? So we talk about like symptoms. So there's frequency of binging episodes, there's restriction, there's purging or compensatory behaviors like use of laxatives. Then they use a lot like standardized questionnaires. Then there is a psych evaluation. Then there are medical or physical evaluation. I know BMI is not a great tool, but we know we use it still. There are vitals, there's lab work. And then there's a psychosocial factors like body image, self-esteem, interpersonal stress. Along with it, what I like to use when I am working with clients are like some of the questions here to make it more culturally comprehensive. Is I ask them about what did food represent in your home growing up? Or has anyone ever connected weight to marriage or appearance expectations? Or were certain foods considered good and bad morally? What comments were made about body size? Who in your family talks most about weight? And have you ever felt worried about body comments when you're visiting home? This is especially for individuals who have immigrated, who live here. This is something that I often hear is, "Hey, I'll be going back home, and I'm very worried because the minute I land, I know there'll be a lot of comments around my body, my weight, my skin color, all of those things, and less about my work or less about how I'm actually doing, less about my own emotional health." And that brings in a lot of like sort of like an anxiety around like now my food will be monitored, now they're going to tell me like I don't fit in certain clothes, and or certain colors don't look nice, or I have to change the way I'm wearing my clothes because I know I will be scrutinized for it. So having them during sessions like prepared when these things do come up when they are flying home, so having that information upfront or having that information like discussed during sessions is very helpful, so that they start realizing like what are their triggers when they go back home as well. Other things that I often like to ask is, do you feel different at home versus outside? How do beauty standards differ between your community and the mainstream culture? And do you avoid any non-home foods? Or did your food preferences change after moving countries? And these things are very important because sometimes like even they don't understand as they are coming in that how their food preferences or how their choices have changed. But when we sort of bring that in the forefront and discuss in our sessions, it is very helpful for them to see, oh, these are certain things that really affect. And they really created like this sense of differentiation or my way of like acculturating to a new community and culture. There are also migration related food changes that I really focus on is have you ever felt caught between two body ideals? Do you focus more on like the beauty standards in general and overall? And then the common pitfalls that I often see in screening is assuming that absence of weight fear is no eating disorders, or over focusing on BMI, or ignoring the caste class pressures which come in within the South Asian culture, even minimizing the male pathology more in terms of, are you focused more on muscle building? Are you focused more on like having a flatter stomach? Are you focused more on looking broader and bigger and taller? Avoiding conversations around marriage norms because that's really, really important to highlight in sessions, and not sometimes even not addressing shame directly, shame around food changes, shame around body changes, shame around how they have been functioning as they have moved or they live far away from their core family. So, what are the basic overall treatments that are used in eating disorders? One is cognitive behavioral therapy specifically for eating disorders. There is FBT, which is family based treatment, which is more used for anorexia nervosa. There is obviously, along with it, we use a lot of DBT and EFFT, that is emotion focused therapy, emotion focused family therapy. But I'm going to focus more on the CBT and FBT aspect as to how to incorporate a culturally supportive treatment to help South Asians feel more seen in our treatment areas. So, when we talk about CBT, I often talk about, say, for example, when there is low self worth, there is over evaluation, there is restriction, then there is binge, and then there is shame. What happens, what I add to it is talking about marriage pressure, talking and focusing on family surveillance. I talk a lot about colorism. I know when I was growing up, there was a lot around, there was this fairness cream called Fair and Lovely. And recently, when I was sort of looking through it, I realized that they have now changed their name to Glow and Lovely. And I was reading through it and I realized that it was because when we were growing up, there was a lot of focus on the white color of the skin and making sure that you are fairer and fairer and fairer. And now I'm very happy to see that, the people, the community, the consumers perspective has changed, and where they focus more on like I want to sort of inherit what I have, I want to sort of highlight my own color. And so now they had to rebrand it to Glow and Lovely. And so it just reminds me of how much colorism also plays a big role, because when they are targeted for their color, where they're bullied for how they look, different shades of brown, that is also affecting how they perceive their own body and always wanting to change some aspects of it to fit in to the dominant culture. The achievement perfectionism, and also adding the immigration trauma. Why it's important to bring all of that into connecting it to self worth or over evaluation is because these things really have a huge impact on how an individual is looking at food, how the individual is looking at their body, and how that affects their overall functioning in the society. So, the sort of case conceptualization I do with CBT is addressing shame explicitly. So, ask, intergeneration narratives, talk about externalization of stigma, do a lot of body image work, which explores radicalized body comparisons, discussing obviously the Eurocentric beauty standards, addressing colorism and fairness narratives growing up or even now, what they hold in them. Regular eating should also incorporate cultural integration. So, when we are talking about food exposures, I often tell parents, if it's an adolescent that's working, I often tell parents, like, hey, you know what, let's bring whatever food you're eating at home. It doesn't have to be what we see in the mainstream culture. So, including rice and roti in exposure hierarchy, challenging carbs as bad. And then, in terms of exposure, I often tell weddings, family receptions, or festivals, using them as therapeutic exposure. So, planning for those things, just like I would plan for, okay, we are going, I know my client would be going for Thanksgiving, we are going to plan around that. Or Christmas family dinners, we are going to plan around that. In a similar way, I also plan around Diwali party dinners. Like, okay, what are we supposed to expect there? What food would not we would normally find? How do we bring that into our sessions when we are doing exposures, and sort of sit through it and see how we feel, so that they feel ready and they have the skills when they have to go out and be integrate back into the society, and enjoy those festivals with them. And then the cognitive work includes a lot of like challenging of slim girls get married faster, being thin shows discipline, or my body reflects my family. Because these are not just distortions, these are cultural narratives. But it is also important for us to challenge them, to sort of see if this is really helping their functioning. In terms of FBT conceptualization, I want to focus on that it definitely aligns more with the collectivistic values. So FBT involves like the entire family, sort of comes together and helps the kid. But I often encourage them with like, if the family feels like, okay, I think like it is my fault, it's often like because of me that this is happening. I often sort of start with like a lot of psychoeducation, which involves like, hey, I know this is secrecy, this thrives more in protection. So we want to sort of focus more on, talking about it more, externalizing the eating disorders from your kid or your child. Also talking about that we are not fighting your culture, we are fighting the eating disorders. That your family strength is an asset actually in this treatment. So, psychoeducation overall is very important in treatment. Other thing is addressing food policing. So, we talk about like, hey, instead of making comments around you're eating too less, you're eating too more, why are you not eating that? Sort of sit with the kid, sit with the client, and in terms of what is happening. Talk to me about like what is the fear, what are you feeling, helping them have those narratives with their kid or with their family member to support them into this eating journey. The other one is also extended family involvement, like our grandparents involved, our aunties and uncles involved in their food journey. And if they are not, sort of helping parents develop this style of parenting where they're able to put boundaries, or they're able to express like, hey, we are following some medical directives for our kid. We would appreciate if you don't make any comments around their food or their body image, just so that they are showing that sort that to the kid that they're protecting them, they're not exposing them to everybody, be like, go deal with it. And the main important part that lastly, that I want to mention, that in treatment, this is where the nuance is critical. That if we tell a South Asian family to eliminate traditional foods because they are too carb heavy, we risk reinforcing the Western superiority narratives and deepening cultural shame. So, similarly, if a teen avoids any cultural food due to body image concerns, parents may interpret that as an assimilation or cultural rejection. So, as clinicians, we must protect cultural foods in the recovery process. We should integrate rice, dal, roti, sweets, and not remove them. Because the goal is not westernizing eating patterns, the goal is flexibility and nourishment within the cultural context. And with that, I would like to open it up for questions.
Thank you so much, Runjhun. That was extremely informative. We do have a few questions, so I'm happy to read them out to you.
Yes.
Our first question is, do you have any advice for someone who marries into a family that has a heavy emphasis on food and food is love and respect? I have some anxiety around these environments and I feel stressed for meal times.
I I know that that can be definitely very, very scary to be in those situations. So thank you so much for bringing that up. The one thing I definitely go in is look for someone within the family system who can truly sort of listen, not judge. Listen to what is going on or why you feel extremely stressed in those situations. The other thing that I often mention is I know we don't like the word boundaries. I don't like the word boundaries either. But putting in perspective of saying, I understand you all love food, and I am someone who struggles with um, food being the main topic of our discussion. How about can we use some other ways of sharing or caring with each other? And I know that can feel very vulnerable and it can feel very, very, it may can feel more of like a rejection of the family system, but that is you sort of putting in your individual perspective in that. And as you go along, sometimes this helps to sort of the family to see that okay, they are really uncomfortable with this. But if you play along with the same thing, they do not understand that this is something that causes discomfort. But I would definitely sort of even recommend like lot of role playing with this, because when we talk it for the first time I also feel very anxious, and then we sort of role play, we sort of start working with it and make it more ingrained in the communication style and the pattern, rather than it just being like a one-off sort of situation where we speak and keep our mouth.
Okay. Another question. How can we handle the comments postpartum about our bodies? I'm nervous if I don't bounce back and then I will get comments.
So I would challenge the idea of what do you mean by bounce back, because it is important to when we are talking about comments, right, it is important for us to understand what do we know about postpartum recovery. I think we all, including me, I know where I was sort of put into this mind frame of, oh, 6 months is postpartum, that's it. And the one thing that I realized through the entire journey was it can take 1.5 to 2 years easy for people to really feel like they're back on their feet and they're able to manage and sort of find the time for themselves. This is specifically because this is also the timeline where the child is sleeping a little more longer. They are able to like understand what this transition means, how it has affected their body. So when we are talking about comments coming from others, I often start looking at like I know someone who would come in and say like, oh, you still look 10 months postpartum. And I would say, yes, I'm happy and enjoying with my child. I'm happy that I'm able to be there and protect my kid. And when we come back home, sort of sitting with ourselves and saying, my bounce back could look more like a sustained recovery process. It isn't a one-stop shop. It isn't sort of like I have to go hardcore, like I can work out every single day for an hour, or I can eat in a similar way every day. It is sitting with ourselves and sort of navigating those expectations of what the culture expects from us and what is reality. So checking in with ourselves often helps. So when there are external factors or others coming in and making comments about the body, I often pause and even say like, I, I have said it personally a lot of times is, hey, that's really rude. I didn't like what you said. And sometimes I would also say, I know I'm trying really hard, and thank you for recognizing that I am postpartum, and like pausing it right there and not encouraging and switching to a different topic right away.
Thank you.
Mhm.
I'll open it up if anyone else has any other questions. Feel free to put in the chat or come off mute.
I
I,
I don't think
I
we
think
can
we're
hear.
having a hard time hearing you.
Can you hear me now?
Yes.
Oh, awesome. Okay. Thank you so much for the presentation. It was really wonderful. I learned a lot and I definitely related to a lot. And I was just wondering what got you into this work and how do you recommend other people who want to work in South Asian health spaces to, yeah, get into this work?
Okay, so I would say this was more getting into eating disorder was very accidental. I, as we said, like we never learned about it explicitly. Like I remember in my grad school, there was my professor actually was an eating disorder expert, and she would like talk a lot about this. And for some reason, that one summer, she said like, "Hey, I'm going to have like this summer course on eating disorder." And I was like, "This looks very interesting because I've heard about schizophrenia and I've heard about depression and anxiety and I've worked with all that." But for some reason, this really like resonated with me, and I took that course, and along with it, I learned a lot about um, how my own journey, my own a very close like family member and stuff, like actually like I made one-on-one, I was like, okay, they actually suffered from an eating disorder and none of us knew, none of us even like recognized it. And how that has created this journey in them where there is a lot of like, even now when I'm around them, I'll be like, okay, I'll be listening to like this eating stories and the way they talk to their bodies and then the self-esteem and all of those things. um, and that is one thing that got me really interested. I was also very fortunate to have a supervisor when I was getting my licensure hours who got me and helped me get trained into family based treatment. And as I started working with different communities, different cultures, I started realizing that there is this common ground of eating fears that come in. And then came COVID. And I think like that just exacerbated like the eating disorder fears and like the fear of like food and weight gain and all of it. And so I often tell individuals is take these disorders when we are learning about it in grad school. It's important to sort of look at it from a perspective of um, we might not see them specifically. We might not look at them as disorders in our face, like depression or anxiety, but listen to in your own circles what do you hear about food. Listen to them in terms of what are we hearing, what are they talking about on a day-to-day basis, what comments people make. And this will encourage you to see that if this is hurting me and this affects me even 1%, I'm sure there are individuals out there just like me who might also get affected by it. And if I am pursuing something to be a therapist or a psychiatrist or to work in this area, I would definitely want to be more educated about it. It doesn't hurt.
Thank you so much.
Absolutely.
And we have another question. Any treatment modalities you would suggest for teen Indian female with disordered eating?
Hmm. I would start definitely with FPT. If it's if it is an anorexia nervosa, I would definitely start with family-based treatment. I will guarantee the teen will hate it. I go into session saying like you'll hate me for doing this, but this is only again I always talk about FPT in a very time frame thing that we are going to do this for say probably like the first quarter. Then we are going to give back the ability to like plate your food to you. Your parents are only going to do a surveillance, then we're going to talk about it. So giving them a more structured approach. So FBT, I would definitely go for it. Um, if we are noticing that the teen is not responding to FBT, I will also look at CBT on some level, but it's really hard if they are not medically stabilized. So I look for medical stability if they're eating in the right proportions, but it is more cognitive level, then I would switch to CBT. But right now, FBT with all the cultural nuances and aspects in it. I will definitely say don't use it directly from the manual. It makes it very difficult to even like relate to it when you're working with South Asian clients.
Thank you, Runjhun. And I just want to also point out we have a wonderful screenshot here on the screen. Runjhun has posted her profile is on our South Asian Care Directory on southasiancare.com. So if you're looking for a clinician, whether it's in this space or any other health space, please feel free to visit our directory to find someone who fits your needs. And if you want to reach out to her, her information is up here as well. But if there's no other questions, then I think we can wrap up today's session. And I just want to say thank you so much to our audience for joining today. And thank you so much, Runjhun, for putting together such a wonderful session. This has been such an important topic, and I appreciate you collaborating and sharing more about this.
Thank you
So,
so much. It was a
yes,
pleasure.
wonderful. Well, if anyone has any other questions, feel free to reach out to myself or Runjhun and visit our website for more events. But thank you, everyone, so much again. Have a good day.
Thank
Bye.
you.
Thank
Bye.
you. Bye.